you know, if you ever see RD, that means that you're a registered dietitian with the United States of America. So it's my national registration. LDM in the state of Texas, I'm licensed to practice. And then I have CSP, which just means that I'm a board certified specialist in pediatrics, which turns to I have the experience. And then you take a test. You never, even when you get out of school, finish taking tests where they give you scenarios of sick kids and you have to tell them the labs you want to order, the tests you want to run, and then based on your answers, they have you answer more questions and calculate it. So that's what all the little words mean. And you can always look it up if you're ever interested. You can go to the, you just type in CDR and then put some initials. You want to know what the dietitian is behind this, you can. This is my road to becoming a dietitian. San Antonio is home to me. I love San Antonio. I leave it for a while and I come back. My undergrad I got from A&M in College Station. And then I worked for a year back in San Antonio as a diet tech, which is someone who has a nutrition degree and can do some basic nutrition counseling so that I could get some experience and figure out what do I really want to go to become a dietitian or what were some other options available to me. Then I applied for my internship. So I went to Baylor Medical Center in Dallas, which is a great program. And then I became a dietitian in June of 2006. So I'll have a picture of the missions because I love the missions here in San Antonio, A&M because that's where I went, and Baylor because that's the hospital I went to. It was a huge hospital. They had everything on one campus. They did a whole variety of services. They probably had 20, I'm trying to think because they have like 22 to 26 dietitians on staff. The hospital, if you combine all of them, probably had more than 1,000 beds. It was a huge hospital facility.
I was born there.
Huh?
I was born
You were born there. It's a great place. So, my experience, like I told you, primarily in pediatrics. I was just lucky when I got out of my internship that the hospital I was a diet tech for, they created a new pediatric position because they realized how important dietitians are. And so I fell in and I worked with kids who had cancer and who needed bone marrow transplants. I've done some outpatient clinics, variety of children, and then currently I work with liver transplant patients throughout their process. And then we don't do short bowel transplants here, but kids go to Nebraska or Omaha. That's two of the centers who do them and who do them well. And so they usually, but when they come back, we're in charge of their post-management care. So I work with the doctors. Short bowel, in case that's your short intestine. So these kids, for some reason, are either missing or their short intestine doesn't work. So you can actually put a new small intestine in them. And it's not as easy as when you give someone a kidney or a liver and it starts working. It can take a long time for your small intestine to start working. Your liver, when you put a liver in a kid, you know automatically their numbers drop significantly. It is so amazing. And kids, the color of your desk is the color of some of my patients. And the minute they get the liver, 2-3 days later, they're looking the color they should look. And so it's pretty amazing doing that. Also, I took some time and I worked with some adult kidney and heart transplant patients, and I've just done some acute care in adults, some general like ICU hospital settings. So I kind of like to just try different things. I like working with patients, love talking about food. I do it all day long. Then I go home and I cook all these crazy meals, and all I do is eat and talk about food. This I have about nutrition and liver transplants. This is kind of what I do right now. I just love it because it is so rewarding to me. These children, as you'll see, they have such a hard time growing. And what your liver does for carbohydrate metabolism is your liver stores the broken down carbohydrates in the form of glycogen. And in these children, their livers don't work, so their body can't store it as glycogen. So similar to diabetics, their blood sugars drop, and so they can have seizures or they can sometimes die because their blood sugar gets too low. So it's really important for us, for me too, to make sure, okay, you need to make sure you feed this kid every 3 hours when they're young. Or you need to make sure that when they're older, they don't go 5 hours without eating. Like most of our kids get overnight tube feedings. Why your liver is important? It stores glycogen. It's a huge organ. It processes toxins that it gets, sends out your body through the rest of your intestines. It produces proteins. So a lot of things, we eat the food, it starts getting broken down in our GI tract, and then a lot of it gets shunted to the liver, where the liver breaks down things and sends it to where, storage if it needs to be stored, or it sends it out like with the bile in either your waste. Eliminates nitrogenous waste, and it stores vitamins and minerals, primarily your fat-soluble vitamins. So most of us don't even think about it. We eat the food, and our liver does an amazing job. Actually, our entire body does an amazing job of saying, oh, Sarah had too much vitamin D today, she's just going to pee out the rest. Or, oh, Sarah, she didn't eat all this extra stuff, so we're just going to let it go out her urine as well. But with these kids, their bodies don't work well, and so their body loses everything. And simple things that we don't think about, like night blindness or just general blindness from vitamin A deficiency, you will see in these kids, and there's studies done. And so we supplement them with, if you and I took, it would be toxic levels. And actually, I was on vacation, so this kid got his liver transplant, and they sent him home, and I wasn't there for the discharge. And the doctors do a good job, and they're not bad, but I am like the nutrition queen, I feel like. And so, this kid comes back, and he's still on this specialized vitamin, and we draw levels just to check. So he comes back, even a week after he got discharged from the hospital, which was about 3.5 weeks after his transplant. So he was discharged 3.5 weeks after his transplant. 4.5 weeks, he comes to clinic, and his levels were too high. And why is that? Because when they discharged him, they never switched him over from the specialty vitamin to just a general pediatric vitamin. So if you think about it, in a vitamin that we give a child, or even that we take a lot of times, as far as like vitamin A, there's maybe 500 units, 1,000 international units. And in the vitamins we take, most of it is as beta-carotene. Because if it's beta-carotene, our bodies just can excrete what we don't need, and what we need, we can turn into vitamin A. But in this specialized vitamin, there's 5,000 units of real vitamin A. And so this kid's vitamin A level had gone from like 2, which was too low, to about 20, which was way too high. So I'm like, okay, we don't want to make him toxic, so we put him on, and his level evened out. But it's real important. Your liver, you can't live without your liver. We talk about that. If you get sick with your liver, depending on how sick it is, even as an adult, you'll need a liver transplant. Your kidney, you can go on dialysis. They even make a machine for your heart that it can pump for your heart, depending on what is the cause of your heart disease. You wear this little, it's a battery pack machine that you can also plug into the wall, and it acts as a pump for your heart. As of yet, they haven't found anything that can replace your liver. Okay, so these are 2 pictures of a liver. I don't know if y'all can see them very well. This is a healthy liver here. From where I took it, it's a donor liver they're actually getting ready to put into a patient. This is a liver of a child with biliary atresia. And what happens in biliary atresia, they don't know exactly what causes it, but the liver can't excrete the bile into the gallbladder, and so it stays in the liver and starts basically eating the liver. And so the stain here is that you can see the necrosis from where the bile has killed the liver tissue, and the ducts are blocked. And so this is what biliary atresia is, what causes most children to have liver transplants in the United States. So if you think about, why do most adults, would you say, get liver transplants? Or what are some reasons that you say adults get liver transplants? Alcohol is a reason. Yeah, past alcohol use. What else did someone say? You get hepatitis, certain types of hepatitis. And there's also adults who just unknowingly, there's no reason for some people. Most reason that children get liver disease is they're born with some disorder where their liver doesn't work or doesn't clear, like bile or other waste well, and so it backs up into the liver and causes the liver to basically just to die. And depending on the child, the last child we transplanted was 6 months old because she had such bad liver disease. We try to get them to at least be a little bit older to grow a little bit more, but when the child gets sick, you have to transplant them. And so it was a race against time for us to get her to gain a lot of weight and to keep her alive with, the doctors with different medications for her to get her transplant. And so also another reason in children that you wouldn't think about, but just in general, if you ever have any young children, my brother and sister-in-law just had a baby, so I don't have to worry about this for a while. But quite a few children end up, like young children, 1 to 5, needing liver transplants because they overdose on certain medications that family members leave out, like Tylenol or aspirin. And so those are things you want to be careful. That's a way we can prevent children. They don't really need, they wouldn't need a liver transplant if they didn't take it in. So just watching, they have child-proof caps, but it's amazing how some children can still get them off. This is a study I put up here. It's interesting to me, and as it shows is when children present, so this is biliary atresia, the most common reason that children have liver disease, and when children present with biliary atresia, which is usually about 6 weeks after birth, they kind of grow about the same way. And if you come here to 6 months after we diagnose them with the disorder, the children who didn't grow very well, which is the blue line, had a worse outcome than the children who grew better. And so what is really, there have been multiple studies that show if you have a better nutrition status, if you plot better, if you weigh more, if you're taller when you have a transplant, then you're going to do better. Well, that sounds easy. As a doctor's like, Sarah, why isn't he growing? He tells me all the time. I'm like, well, you know why he's not growing. These kids, they don't want to eat. Their liver, is huge. We had a girl one time, and she had a tumor in her liver. They took the tumor out. She weighed, I'm trying to think, she weighed about 25 pounds. They took the tumor out. The tumor weighed 10 pounds. So, and you could see she looked like her arms and legs were like this big around, and her belly was huge because it was her liver. And so if you look at weights on these children, you're like, oh, I see her weight, and I'm like, oh, she looks great. She plots really well. No, I look at her. No, it's all in her liver. And so the thing about it is, though, when your liver's that big, you don't want to eat because, especially when you're that little in general, your liver presses on your stomach. It also presses on your lungs, so you don't want to breathe as much. And then that just makes you feel bad, and you're tired, and so you don't eat. And her stomach, she would eat actually, but she would eat half a piece of toast, and she would feel full because of her liver pressing on her. And so for her,
Is that why, when you see pictures of starving children, their stomachs are really swollen?
No, for pictures of starving children, the reason is because usually they get some calories. It's the way their malnutrition and the fluid in their body. So it's not necessarily because their livers are big. It's just fluid displacement from the fact your body likes to stay in balance. And if you don't get your calories from a balanced area, your stomach can get big, but it's not their liver. But that's a really good question because she looked just like one of those children. But hers was a different reason for that. I don't know. So for her, we had to put an NG tube down, and it's really a struggle. I'll tell you, my job is parents feel like failures. I spend a lot of time educating parents, and maybe that's why I like my job because I do work a lot with adults because I educate parents all the time, and then I work with children. But because parents are like, but she eats, and she weighs 25 pounds. Yes, but we didn't know. We took the tumor out, and that's where it found out. But the doctors even estimated because they did some tests. I'm like, yes, but she doesn't get enough. But look at her belly. Her belly's big. It's not a healthy big belly. And they're like, but she's gaining weight. It's not the right kind of weight, And they don't want to put that NG tube down because have any of y'all ever had an NG tube? I've been told they're very uncomfortable. I want someone to put one down me just so I can try it. But I've seen it put down. When I was doing an internship, the dietitians actually used to put NG tubes in patients. When patients are asleep or intubated, no problem. The guy I saw did not want it in, and he was gagging, and so I'm like, if you put it in me, you have to sedate me. But I want to, and I want to because I want to know what it feels like to our patients. Because here I have a 15-month-old with an NG tube coming out of his nose, so that I can just, how do they feel? So one of these days, maybe you'll see me walking around campus with an NG tube for a week, just to try it out. I encourage you, in whatever profession, to try it. My diabetes rotation, we had to prick ourselves. We had to test our blood sugar 4 times a day, and the little monitor, of course, it had like a 6-week reading, so our teacher could tell if we tested our blood sugar. It tells you what time, and only she locked it so we couldn't change it. So it told you what time you checked your blood sugar, so she could tell if you checked it at the right times, if you checked it, and then if you're doing what you're supposed to be doing. Well, that's all fine, but you know what? I mean, I've seen kids like I've seen open chest. There's all these wounds, people like all this crazy stuff coming out of every orifice. Doesn't bother me, but if you put a needle, I'm like, I have to leave the room, please. My mom, she's like, I can't believe you. My mom's a nurse. It is. I mean, when I used to work at the previous hospital, we'd have all these little kids with you get fluid overloaded, so they keep their chests open. Didn't bother me. I mean, you have to gown up completely your hair, you have to wear a mask, you have to cover your shoes, so I have to go talk to the parents. And I'm like, oh, we're fine, no problem, this kid half open on the table. But the nurse would come in to like give them something, even in their IV, not into there. I'm like, I have to go sit down, I can't watch this. I just don't like needles. And oh my gosh, this was so hard for me. The first time, kid you not, I had to go sit in the bathroom and almost passed out because I started hyperventilating. Pricked my hands on with the little with the blood monitor. But I now know how people must feel when I say, and then even though I had to do it 4 times a day and only did it for 2 weeks, my fingers were so sore. I mean, I would be like 1, 2, 3, 4, 5, 6, but you run out of fingers and you have to go back. And so I encourage you, in whatever you choose to do, you need it if you can. Try it in your patient's shoes or in your client's shoes. One of my fellow students in my master's class, she's not a dietitian, she works for an insulin pump company. And I feel bad for her because she doesn't even, she's a biology background, but she was like, I'm helping patients with their insurance. Well, they made her wear an insulin pump for a week. She had to insert it into herself. I'm like, you're better than me. I've probably been like, oh my gosh. But the same thing, and it measures your blood sugar and everything. But so that way she knew how these people would feel and have a different perspective from them. So I frequently talk of random stories, and I will get back to my subject, and I'm very sorry about that. But I really like what I do. So anyways, back to my NG tube. So a lot of our kids need NG tubes, which if you don't, that's a nasogastric tube. We don't really put G tubes in them because when you do surgery, it can affect their liver replacement later. But we get a lot of NG tubes in them because they don't eat. If they still don't grow, we have one little boy, and he gets 150 calories per kilo. To put that in perspective, you or I on average eat about 30 calories per kilo. Most kids eat about 80 to 90. And so I have this little boy, and we're giving him 150 calories per kilo of a formula. I add everything you possibly can add to a formula, and he's still not growing. So now what is he doing? Now we feed him TPN in his vein. Has anybody ever had an IV? See, more needles. Oh my gosh. But what we do is, instead of, like most people, you'll get them like in your arm or here in your elbow, is that he'll get a central line, and then so it'll infuse into his central line. But what we do is, what my job is to make sure that he's getting protein, calories, and fat in that TPN, and it's all broken down for him to tolerate it. Talk about your liver and fat, which is what you're going to talk about. A lot of these kids malabsorb fat because your liver secretes bile, and bile helps bring the fat so that you can digest it. Well, when your liver doesn't work, you don't secrete bile, so you get a lot of diarrhea. It's really bad smelling, and so these kids have to be on a special form of fat, which tastes really bad. I know because I've tried it, and it smells like dead fish. So it's another reason we give them NG tubes, because we also have, think about a 1-year-old, they're learning to eat. Last thing they want to be eating is something that tastes bad. And it helps with oral aversions. However, I do have a couple kids, they will drink a liter of this stuff, and I don't know how they do it, but they do. And it's good because it helps them grow. But it's a special type of fat, and I don't know if you can get into that, but it's called medium chain triglycerides. And your body doesn't need, it can be absorbed through your portal system, which may be too much, but it doesn't need certain parts, so it's easy to digest, and then we can help these kids get a really high source of fat in their body. This through their vein, it doesn't matter because it bypasses your digestive tract. It goes in there automatically. Anyone want to be a nurse? No, you want to. Nurses are cool. My mom and I have so much fun discussions about nursing and nutrition. But it's real important if you ever see people with TPN, if you're a nurse, they need to have filters. Filters, TPN is all your body. It's basically the food that you had for lunch, ground up and pulverized, and then sent through a machine in a bag. So it's like the sandwich turned into glucose and a little bit of amino acids. And that stuff can still filter out. So you always want to use a filter because that way it won't get sediment into someone's veins. That's a very bad thing to do for that. Anyway, so back to my children. It's really important that they have nutrition to grow. And it's the doctor, he means it jokingly, but he's always like, Saralyn, you're not making this patient grow. And he and I both know, because he has a lot more experience in this than I do, these kids have a hard time growing. And there's a lot that needs to be done. We'll bring them in every week. And their parents are so good, because I see them every week to make sure that they gain weight. And it's a constant struggle. We gain, less than a quarter of a pound one week and lose it the next week. But it's really amazing to me the last, because we transplanted these kids, and then too, they get a new liver. So this kid, remember this other kid needing 125 calories per kilo. So we see him a week. Takes him a while to get all this stuff caught up. And then, oh my gosh, now he's huge. Mom stopped giving him all these supplements. Because now he eats everything. He feels better. He's his original color, which we all thought his dad's dark, his mom's real light. And he's really light, which we thought he's yellow, greenish yellow, for a long time. And so we're all happy. He looks so good. He's eating. He's not yellow. His eyes aren't yellow. He's about to start walking. And it's a really rewarding job for me to be there and to make sure that I know I helped this kid have a better outcome, because I made Mom come in every week, and I just did that tooth feeding and got him a little TPN when he needed it. But I'll tell you, it's sad. Working with kids in any aspect is very sad as well, because people die all the time, but seeing children die sometimes is a lot harder. And I say they haven't lived their life. And what did they do to deserve that? And it's just, I can't tell you, it's really sad for me. I cry at least every time one of our patients dies. I think because we're close to them as well. But each of them, I feel they've done something good while they were here. Each of these kids. And it is still a rewarding experience to have helped these families and to have supported them through their ordeal and to done whatever we could for when they were there. And to learn from the families and the children, and to be able to help those who can and who succeed and who now bring us colored pages and are growing and talking and reading, and it's really amazing. So what I do on a daily basis, I monitor the growth. I call parents all the time. I just tube feedings. I work at their vitamin supplementation, like I told you. We don't even think about it. One of the vitamins that I don't do all that much with, I just make sure they get, but the doctor checks vitamin K, which does anyone know? Vitamin K, I don't know, maybe you have grandparents on Coumadin, they tell them not to eat spinach or certain foods, leafy greens. Do y'all know why? Coumadin and all those vegetables, especially when you're going to nursing, you teach this to all your adult patients and some of your children. It affects your clotting. So if you have too much vitamin K in your food and you're taking Coumadin, or you have liver disease, it affects your clotting. Liver disease is the opposite way. They don't have enough vitamin K, so they have other clotting factors that are messed up, so their blood likes to get real thick. Whereas if you're on Coumadin, by the way, not having to do with liver disease, we hardly have any patients on Coumadin. But if you take Coumadin and you eat a lot of spinach, or you eat a lot of leafy greens, or a lot of high vitamin K foods, it'll make you bleed too much. Interesting story. Back when I was first a dietitian, I was helping covering this adult floor. this woman, and she seriously, she was between 85 and 90 years old. She was purple, like basically from her neck down, because she thought the doctor told her to eat more spinach, not less spinach. She was taking this medicine, and it was her body bleeding all over that she was purple. And so it's really important about education on things that I teach myself, like you need to be really, like write it down and tell people multiple times. And they may get annoyed with you, but you'll be amazed at how many times people don't hear you. And that the woman was lucky. I mean, she could have died from that, but she's really lucky that all it was, she just needed to not take Coumadin for a while and not eat any more vitamin K, which we went over like twice a day until she went home. But it's really important to just say, okay, this is what's going on. Also encouraging appropriate development of eating patterns. Don't know if anybody in here wants to be an occupational therapist or a speech language pathologist, but they are all about eating. And that's good, and I'm all about eating too, but I also know that kids need to grow to do better in liver transplant. So I have a good rapport with the speech therapist. We like each other. I have a lot of respect for the speech therapist. They do amazing things in the children's hospital. They're amazing. Like to even go see them one time if you're ever in nursing school and you want to be a nursing, or if you're going into therapy, to go watch how these people, it takes months for a kid to like want to touch a gummy bear and some graham crackers. And they are just so persistent about it. It's really neat. But working with them, because I know these kids need to grow, but it's also really important because what you learn when you're young is how you eat. Think about certain foods you don't eat as a kid. Or I mean, now. Like who can tell me, does anyone think they have a weird, I can tell you, I cannot eat raisins. Well, actually, it is a better one, because I blame this on my mom all the time, just to be. But I cannot swallow a pill. I'm very bad at it. And to the point where the doctor starts giving me chewable medication. My mother started putting rice cereal in my bottle when I was a baby. You're not supposed to do that because it messes up with your swallowing. So I always tell her that she didn't feed me correctly. That's why I have a hard time swallowing pills and I have to go get it taken care of. But it probably has no correlation. It might. But there's a lot of things that happen when you're young that can continue even to adulthood. One time I was here on UTSA and I was talking to this girl. I was doing a nutrition thing over in your cafe before I was even a student here, and she was asking me about how to increase textures in her food because she just didn't know how to do it because she had had aversion since she was a child. And so it's a combination for myself and the speech therapist to work together to say, okay, they need to eat correctly because if they don't eat now, they may have weird and disordered eating patterns when they're adult. But I'm like, but I need to make sure they grow. So we work together. A lot of times we'll try and do feeding. I'll try and do their tube feeding overnight so then they can still eat during the day. Or even if they don't eat, we still have them sit at the table with the family. They're allowed to play with their food and do different things just so we can keep it as normal an eating pattern as possible. And family support, a lot of family support. These kids are sick, they don't want to eat, they don't understand. Even other family, like I'm seeing this mom, she's like, oh, well, my aunt says I'm not doing a good job because, well, her nephew is twice the size of my son. That hurts mom's feelings. And so it's like, okay, but your son has a disorder, or he doesn't, for certain of them, they just don't grow very well. It's a genetics thing, and so it's a lot of family support for the whole team involved. And it's neat to work too. Like there's a nurse in the clinic. There's a nurse in the clinic. I work with the transplant coordinator who is also a nurse. There's a social worker. There's a speech therapist. There's the doctor, and we work together to do what's best for the kid. And that's really how medicine in general is going into multidisciplinary care. So I encourage you in whatever aspect, if you go into any sort of medicine, even as a PA or a nurse practitioner, or even if you're not, if you're just a patient in the hospital, which you will be, appreciate, that these people work together and work as a team and try really hard to do the best that they can for you. And if you ever want to see a dietitian when you're in the hospital, just tell them, I want to see the dietitian. So many times, like, it's amazing to me because I'm a dietitian and I know how my grandmother eats. So she gets into the hospital, she's diabetic. My grandma is my greatest teacher, by the way. She teaches me all the things to make sure I tell my patients and the ways to ask questions. And I'll tell you one story, one of my favorite in a minute. But she's there for a week. She doesn't get any education. Mind you, her whole time her blood sugars are in the 300s and they should be less than 120. Like, I think she need to talk to her. And it doesn't work when I talk to her because I'm a professional. I've been doing this for quite a while. Well, she's like, oh, it's just my granddaughter trying to tell me to be healthy like she's been doing since she was in high school. Not, oh, it's my granddaughter, the dietitian, who knows what she's talking about. But that's okay. My family, they probably would, no, actually my grandma knows. I tell her all the time, I tell stories about her. But so one day I'm getting new, I'm the new dietitian, I'm gonna go change the world. I still am gonna go change the world, so that's okay. But I'm like, my grandma's like, help me with the diet, Saralyn. I should have known because she pulls out from what a previous dietitian, like, covering this table worth of paper. So I said, okay, let's talk about it. I give her plan out her diet. Mind you, I'm pretty liberal because I know my grandma. So I come back, I see them every week, but I like wait a month to ask her how she's doing. She's like, I'm cooking all this broccoli and spinach. And I'm like, I'm so excited for you. Like, wow, this has never happened before. My grandfather happens to like walk by because he's like, well, she cooks it, but she doesn't eat it. But did I ask if she ate it? No, I just said, hey, how's it going? And she's like, I'm preparing it. And I was just excited that she's making it, which I still was excited. But if you don't ask, do you have your medication? Well, yeah, I have my medication, so here. But the whole bottle's there where your patient obviously didn't take their medication. So it's, do you take your medication? Yes. A, do you have it? And B, do you take your medication? Because they will find any ways to not have to tell you the truth because they don't want to disappoint you. They're not trying to be bad. Think about yourselves. Because really even well-educated people, I was reading this study, I'm trying to think where it was, but it was a pretty high number of people who don't take their medication, like antibiotics or even regularly prescribed medication on a regular basis. And these aren't even uneducated people. These are people across all economic levels, yeah, all economic levels, all education levels. They're just like, oh, well, I feel good today. I'm not going to take my blood pressure medication. I'm not going to take my diabetes medication. So it's always something you want to be careful for is how you ask your questions, because that can sometimes lead you to another time. Adults are funny. Kids, when they're little, I know they get what they get or don't get because they usually have the parents write it out. And I can check their growth based on growth in the hospital. But adults, and it's amazing, like, they just, I don't know, they make me laugh. But I had this woman in the hospital, the doctor's like, you need to fix her diet. Okay, so I go in and talk to her, and she's like, well, I mean, she tells me what she eats, and I looked at what she'd been eating in the hospital. I'm like, you eat, it's basically the same thing. Why are your blood sugars 400 at home and 200 here? Well, the doctor never asked her. Well, she was depressed. She just had no family support at the moment, and so she stopped taking her insulin because she was tired of having to poke herself. Well, I could tell her, even if she just ate protein, her body would still break down her carbs and raise her blood sugar. It wasn't her diet, it was her medication. So always simple questions, because sometimes, not all the time, but sometimes simple things can just tell you a lot. These are the 3 most important tips when I talk about transplant. Hand washing, which should just be an important tip. I know I was talking to Kirsten before about, she's like, man, it seems like everyone I know has been sick in the last month. So many things because people don't wash their hands. Just wash your hands. It's not that hard, or carry alcohol sanitizer. But for these kids, that can mean a huge problem. You know, especially we get all these toddlers, and it's really hard for parents because think about, I don't know if y'all know how many little kids or know any little kids, but they're playing on the floor, then they want a snack, and just give them Cheerios, hopefully. I saw a kid with Cheetos. I'm like, give them Cheerios. But eating Cheerios or Cheetos or whatever it is, and they don't wash their hands. And for a lot of kids, that's fine, but our kids are immunosuppressed so that they don't reject their liver. So that can end them up in the hospital. One time, food safety is huge. We don't think about that either. I don't eat any blood in my meat, ever. I'm like the reason my family always has to wait 10 minutes longer because I want everything well done. Well, that's because my food bacteriology professor in college, and I think I took that 10 years ago, but he was very persuasive. But if you're ever immunosuppressed or taking a certain medication, you want to be real careful with food safety. We had a kid, he ate chicken that wasn't cooked, and he spent 2 weeks in the hospital because he got so sick. So with any sort of immunocompromised population, you want to be careful. And no grapefruit or pineapple because it interacts with your medication. Really, grapefruit interacts with a lot of medication. So if you take any medication, you might just check. It's all on a lot of lists of don't eat the food. So I go over to my grandparents. There's like 12 grapefruits. They're both on 3 medications that they shouldn't be. I'm like, I'm taking all the grapefruits home. So I go back and I tell them, don't eat grapefruits. So I go back, this was like a year and a half ago, I go back, there's 6 grapefruits over there. I'm like, I'm taking the grapefruits again. But I love them, they're so good. I'm like, they're not good for you. Other thing I know I just like to touch on is that I work with liver transplant. I like to talk about food. I like to talk about food so much that I do it for the local dietetic association. I don't like politics. Won't get into a political discussion with you. I don't even tell my husband who I vote for because I don't want to talk about. But what I go and do is I educate legislators on just nutrition and the nutrition that is affecting our population. Because a lot of them don't know. They don't know about obesity rates or how it, and it's really great, to do that, to just go and say, hey, I just want to update you on nutrition. I don't care who you belong to, you eat, and you gain weight, and you lose weight, and you have kids who have problems, and so let me tell you, what nutrition can do for you. And I've gone to DC, and I've gone to Austin, and I have a lot of fun. And so I encourage you that whatever field you get into, that you get involved in your association, and you just talk to your legislator to let them know that your profession, why your profession is important. So that they don't know, they have a lot of things on their mind, and some of them have medical backgrounds, some of them do not, some of them have farming backgrounds, and so they're important for different things. But just to let them know, hey, this is out there as well, and I'm listening to you. It's really a neat thing to do. So I think that's the end of it. I think I've talked a long time. I'm sorry. I like to talk about food and nutrition, but if y'all have any questions, I will answer any questions.